Let me introduce our first speaker. I think Holger Schünemann, in fact, doesn't really need to be introduced to this community in great detail. But Holger Schünemann, he is a professor of public health and preventive medicine and director of the Clinical Epidemiology and Research Center at Humanitas University in Milan, Italy. And Professor Emeritus of Clinical Epidemiology and Internal Medicine at McMaster University, Canada. He is currently the chair of GIN and co-chair of the GREAT Working Group. He is also still active in internal medicine to remain directly involved and engaged also with patients firsthand. So with that, Holger, over to you.
Thanks so much, Tanya, for the kind introduction. And yeah, I also would like to acknowledge Ed, who can't be here today. And our thoughts are certainly with him. So thanks very much for the invitation to kick off this particular session. And I'm going to talk about bridging divides and offer some thoughts about empowering our global health decision-making ecosystem. Here are my disclosures. I have primarily to acknowledge the many colleagues that have helped putting the work together that I'm going to present again, and that are going to help in the future. And I will mention a number of names. I hope I will remember that during the presentation. I was planning to not have slides, but then was advised that it might be better for those who, like me, are not non-natives to present slides, in particular for some of the more complicated issues. So today's talk is going to focus on a theory that we have developed a few years ago, and how the elements of that theory are actually playing out, what examples exist where we have made some progress, and what the next steps are for the community in considering health and social science developments in the use of evidence. And I'm going to start with a brief introduction. So Mike and Falavinha is in the audience here today. We did this work together a few years ago in Brazil, where we looked at how within the same ministry or within the same institution, two streams in the evidence ecosystem, HTA and clinical practice guidelines, were essentially not interacting because I think to a large degree because they didn't really realize that they were working on very similar issues. This is the result of a SWOT analysis that we did, where I think the players in the system became very aware that there was a lot of common elements in both the practice guideline process as well as the HTA process. And again, that's one example that led to the theory that I will explain in a second. The second example comes from Estonia. So many of you know that we've done a lot of work with the Estonian WHO country office on guideline methods and capacity building in that system. We in particular identified an example that dealt with the use of direct oral anticoagulants that are often used in the context of blood thinning, obviously, in the context of atrial fibrillation to prevent strokes. And there was an application for inclusion of new oral anticoagulants that was actually rejected at the WHO level for the essential medicine listing. And at the same time, the Estonian national guideline body, which is the Estonian Health Insurance Fund, had made a conditional recommendation for the use of DOACs in certain conditions. And the conditionality was hinging on the fact that the cost was too high for that. That was based on a systematic review and a health technology assessment. Price negotiations ensured and followed that, and the Estonian Health Insurance Fund, together with those who were actually paying or making policy around that in the insurance fund, as well as the manufacturers, came to an agreement to lower prices, and that led to a strong recommendation. And in this context, DOACs were listed in the WHO EML. So you see that there are lots of parallel processes. They are not necessarily connected. Is Estonia following the essential medicine list that WHO is producing? We don't really know that. They certainly made a recommendation despite the fact that it was not listed, but those are all actors that are relevant in our ecosystem. And then the third piece of background, most of you will know about this, I'm just going to show it as a brief reminder, are the evidence to decision frameworks that were a result of a big collaboration with many organizations led by the Great Working Group, and that helped us to structure decision-making processes from initiating or formulating a question to considering criteria. Pablo Alonso is here in the room who can talk more about this, who led most of this work. These criteria being evaluated through on the basis of systematic reviews leading to recommendations and then decisions. So this is the background. On the basis of that, we worked with many of those players on what we called our theory of everything in health decision-making, and described with some support from WHO country office, the WHO Euro regional office, and the authors that are listed there, described how we think these things connect. So in most situations, we make decisions about interventions. That is not to diminish the importance of diagnosis and prognosis and other elements that are relevant in order to implement interventions that are relevant to be evaluated. And obviously it starts with the PICO question. We summarize evidence from primary research in using systematic review methods. And then there are these different actors, for those of you who haven't seen it, different actors in the ecosystem of health decision-making. HTA, guidelines, quality improvement, it's a group or a stream that is not very closely related to or integrated with us, the people who are here today. Coverage decisions, I mentioned the essential medicine list, and evidence-informed policymaking. And what we noticed was that all of these actors use very similar criteria as main criteria for decision-making. So how important is the problem, the benefits and harms, values or the importance of the outcomes, cost effectiveness, and of course how sure we can be in this information. Then there are factors that are related, variable, oftentimes different nomenclature being used, but somehow interconnected. Equity being one, obviously. This has also to do with whether or not an intervention is feasible, acceptable, and so on. Those criteria differ a bit across these different disciplines. Modeling is utilized in most of these decision-making contexts. One draws conclusions, either in the form of a recommendation or a decision that is made, such as in the HTA context. Policymakers like to see options. I think all of this belongs to the system, to the ecosystem of evidence-based decision-making, and I'll be happy to talk about evidence-based versus evidence-informed. This leads to products, and another group that is critical in this whole process are obviously regulators that often use systematic review methods, but more often don't. And that then leads to decisions for different contexts, clinical, public health, and health systems decisions. Implementation follows in many instances. There's research about implementation that we consider part of our primary research, and that together then influences, hopefully, what is done in the primary research context. I'll get back to that in a second. But that's our theory overall. Okay, so I'll give you a quick example for how these different actors could connect and what has happened since. So here's an example from thinking about how these different actors could work together. One observation in the field is clearly that primary research, systematic reviewers, health technology assessment, clinical research are thinking about health outcomes very differently, despite efforts like COMET that has focused primarily on standardized definitions for clinical trials, ignoring that has direct impact, not ignoring, but not engaging the community, that has direct impact on outcome definitions that are relevant in clinical practice guidelines, in quality improvement processes, as well as obviously in HTA and then in our guideline recommendations. So an area where we've made progress is to start harmonizing how people look and different actors look at outcomes. The theory will help, I think, will help with understanding what perspectives different groups bring to the definition of health outcomes. And it's not only clinical trials and systematic reviewers, but it's also those who work in quality improvement and assurance. The second progress, this is work that Thomas Piggott, who is here, has led, relates to the essential medicines list. And Lorenzo Moya is here as well, who can talk more about the essential medicines list, of course, if you pin him down. But the second progress that we've made is to look at how these actors, those who work, for instance, in the systematic review or guideline field, relate to those who make decisions about whether or not a medicine should be listed on the WHO essential medicine list. And what this work revealed is, as we surmised in our theoretical work, that there is a lot of overlap, but that there's also a lot of work that still needs to be done. So, for instance, about definition of whether or not a problem or an intervention in medicine is actually a priority and how this is being seen in the public health relevance. Something may be a priority for a clinician, thinking about the three different decision makers, but it may not be a priority on a public health level. But the work utilizing the evidence to decision criteria and the framework has certainly helped to understand how these different actors relate to each other and how we might be better able to connect guidelines to, for instance, essential medicine list decision making. And indeed, DORICs are now listed by the essential medicine list of WHO. I'm certainly influenced by systematic reviews that have been done. So, what do we have to do going forward? I'm going to give you a few examples of the work that we think we have to do, and that is a result of scientists reading our work, others reading our work, and asking us questions. So, for instance, where's the view of people with lived experiences in all of that? If you looked at the author list, it was fairly small. We did not have a real person with lived experiences in that. We thought at that time that we need to move this forward, and that by considering, for instance, outcomes from a patient perspective, we would have good representation, but it's very clear that we didn't have that. So we need to much better, in a much more rigorous way, involve people with lived experiences in this theoretical framework. The issue has been raised how quality assurance that is a bit different from our quality assurance and improvement that we see on a clinical or even system level, how quality assurance that relates to pre-qualification of medicines comes into play. And pre-qualification is a process that was developed by the WHO, as it ensures that essential medicines actually comply with standards very much related to production of them, and how these type of actors actually relate to our theory of health decision making. And what is really important, there's a lot of writing about the ecosystem in the global context and in health. What is different here is not that we are talking about processes necessarily, we are talking about an underlying theory that leads to decisions and the utilization of criteria. But I'll get back to some of the other issues that relate more to processes in the later slides. And we haven't engaged the primary research community to the extent that we should have done it. So, for instance, most of you will know that I don't like this term particularly. What is the role of real-world evidence in the implementation, in particular around implementation of interventions that we are identifying? So, let me come back to the overarching scheme. Some of us believe that the overarching scheme that we are seeing here, or the theory, might help us to identify particular research gaps. And the rest of my presentation is going to focus actually on research gaps that we might be able to identify. I mentioned the essential medicine list connection, the research gaps that we might be able to identify when we apply such a framework. One relates to, for instance, how we measure benefits and harms, and work around decision thresholds. So what constitutes a small, moderate, and large benefit from administering an intervention or accepting an intervention is based on decision thresholds. And I think a direct consequence of using this framework and the ETDs has been to start defining decision thresholds. Gianpaolo Morgano and Wojtek Wierczak, also both here, have led a great deal of work that helps us to better identify across different work streams here what constitutes a particular benefit and harm. The other issue that I think we are appropriately addressing now but need to better integrate across the different evidence streams here is equity considerations. We focus a lot on guidelines and systematic reviews, but what about quality improvement? What about EML? And then how modeling should be done. There's a lot of primary research, but I don't think that it necessarily addresses the type of questions that we have. So I want to give 3 examples with these 3 perspectives now where we have identified such research gaps and possibly have made some progress. So the clinical public health and health systems perspective. The first is our post-COVID-19 condition guidelines that we are developing with support from the Public Health Agency in Canada, where we brought together, you will see on this scheme, where we brought together at least some of these different actors and are trying to address multiple recommendations and decisions and actors at one point. So we are working in parallel with those who work in the field of cost and health economics. We are working with the people with lived experience community in order to identify priorities, these PICO question priorities. We're working on quality improvement and quality indicators in one go. So starting with the design of the project, we are thinking about these different actors in the health stream. Similarly, this is the work of the European Commission that we have been involved with on cancer screening and diagnosis, 3 different topics. Similar type of approach where many of these considerations are brought into the planning phase. But we have also utilized these 2 efforts, so the more clinically oriented and the more public health oriented work, to identify gaps. So I mentioned the decision thresholds, and it becomes very obvious if you sit with panels and decision makers that everybody asks, what is a small benefit, what is a moderate benefit? Yet we have not fully explored this, and I think we can actually do a much, much better job in working with different fields to come up with answers that helps those decision makers, and that these decisions then, or these judgments, can be transferred across different streams. Another one relates to cost effectiveness. So I want to make this point. We think that many of these issues have been sorted out working with panels, really applying this type of work. We feel it has not been figured out. So the example is the following. Having consistent cost effectiveness thresholds, for instance, in our Canadian guidelines, where we have a fairly complicated model of guideline teams developing recommendations. They get approved by a central guideline development group, and in almost any recommendation, the question comes up, what is an acceptable cost effectiveness threshold? Then we engage our health economists, and they go back to work that is fairly old and provide us with information, yet the judgments, nobody feels totally comfortable with the judgments because the thresholds are old or the work has not been done to the extent with the detail, at least that we would like to see it. And the same issue arises in European guidelines such as these cancer screening and prevention guidelines. And the framework helps us, I think, if we look at it as a grid, as a underlying theory, helps us to identify these particular research gaps. So, and what is interesting here, because this is a meeting, an evidence synthesis meeting that involves social scientists, What is interesting is that many of the questions that we have are actually questions that should be answered by social scientists when we talk about clinical practice guidelines. That has to do with health economic considerations, as I just described. It has to do with these decision thresholds, because how to figure them out involves a lot of work around values that people place on outcomes. Are values different in a clinical context from a public health context? It involves issues around group processes. I get asked all the time, how large should our guideline panel be? And then we give our standard answers. In reality, I think we should be doing much, much more work to understand what representation means in a public health guideline of stakeholders, how large groups really need to be as opposed to the standard 12 to 15, because that work has not been done. And there's a lot of possibility by thinking about processes across the theory to do research that will inform these answers much, much better. So group processes, size and composition being one example. And then, of course, there are the more health research methods oriented questions, the decision thresholds that needs to be done in tandem. So it needs to be done together with those who work in the social sciences. And I already made the case for decision thresholds across the system. And I mentioned the cost effectiveness in various settings. So that is a real, I would say, a real big gap. And I will show you some work that possibly helps us moving into the right direction. Foundational science, of course. I think that many of the questions that are relevant for practice actually are a result of decision-making processes such as HTA and clinical guidelines. So I'm going to give you an example about how we need to better integrate social sciences. So this is actually work that addresses one of the fundamental issues that I think everybody who has worked in an HTA or in an international HTA or guideline context has faced, and that is how to really adjust cost-effectiveness thresholds on the basis of the context. So this is about a method that helps us to address what I exactly said. So if we sit with the European Commission doing a guideline on screening and prevention, there may be ways to say these are the cost effectiveness thresholds that you should be utilizing in your countries in order to implement the recommendation. And then the final level is obviously the health system level. And I wanted to talk a little bit about next steps. So that really relates to building a community that unites around a framework. It doesn't have to be this framework in order to identify these research gaps across different groups. Because again, if we stay narrowly in our clinical practice or HTA field, we will not be able to bridge across these disciplines. So to identify gaps that address common challenges. And this is about setting a research agenda. It's not about the products, which is very different, and we can debate that, of course. So we're working with partners, and we are doing country-level evaluations. So if we use the theory, we are attempting to do a mapping across the globe of who the actors are in the various jurisdictions that already exist and that should be there, starting, for instance, in work that we did with the WHO country office in Slovenia, and in order to then explore the applicability of that theory across more jurisdictions using case examples. And this very much feeds into work that Tanya is leading, on the Global Coalition for Evidence, where I think these type of theories will be extremely helpful to address or identify at least the research gaps that then together these different disciplines that we are representing here could solve, because we are not doing it well at this point in time. So the key points are that the framework is there to help with evidence-based decisions, obviously, and it is very clear that nuances and context is required and must be allowed so that there's flexibility, but that we can use frameworks like this that are different from just describing the actors and the processes, that frameworks such as this can help to identify research gaps that are narrower in the clinical context to a broader public health and health policy context. And I wanted to thank the individuals who've worked on the theory of everything in our next steps, which are meetings to further develop that, in addition to again, Wojtek Wieczek and Robbie Newflat, who've worked in particular on the CAN-PCC guidelines, and remind you that our next meeting with the Guidelines International Network will be actually in Geneva, where these type of things can be discussed in a broader context, and our theme will be innovation and partnerships for health in all policies. Thank you very much.